Thank you, Rohit. Pleasure being here in this Lenticule Conference, which actually puts a lot of emphasis on the science and art of lenticular extraction. I think Rupal is somewhere here. Rupal brought the smile into India for the first time, and now with every other machine coming up with new lenticular procedures, I think that's the flavor. Entire Asia, I would say, has been swept by the lenticular extraction, though I think US is doing a catch-up just now. We were fortunate to be associated with the first unit of ELITA, and starting of December 2018, we started with the flap study and then went on to the lenticule, having done the first case in January 2020. Had always the pleasure of talking with Rohit and his team who joined in for the trials of ELITA and bringing silk to fruition and being commercially released. I think there are more than about 25-30 units in the world today. Well, let's just look at this femtosecond laser as to what it is. And the ELITA femtosecond started as a cheetah trial because it was the fastest laser on the planet Earth, that it was. And silk was the name, and that was smooth as silk is what they wanted to call. Now, when you look at the ELITA system, this is obviously designed as we are sitting here for a flapless refractive procedure, doing a lenticular extraction. And when you're doing a lenticular extraction, the basic advantage of this lenticular extraction is that it gives you a biconvex lenticule, which is the only lenticule that is available by any machine, which is a biconvex lenticule. And Rohit and his team have done trials to show that the amount of induction of abrasions is the least in this, and rather there could be some improvement doing a biconvex lenticule. Now, this laser, apart from that, delivers low energy treatment. And how do you deliver low energy treatment? Is that the pulse duration is ultra short. It is one of the shortest pulse durations that is there. But to overcome and to keep the time less, it is an ultra fast pulse. That means it is firing at a repetition rate which is very, very fast. Small focus spot size, and what this does is that as the spot size is close to about 1 micron, there is no spot separation which is there. So bridge free or the tissue dissection is pretty easy. I think there's going to be a live surgery just now that's there. The disruption of the tissue is much less, and the quantum of energy that is delivered on the cornea is considered to be about 30% less than what it was with the other machines. So you can have this, you can fix the optical zone. We normally do it at 6.2 or 6.5 as the optical zone, and bring out the transition zone by about 1 millimeter. Entry incision can also be changed, as you can see, from any location, as also from 2 millimeters to 5 millimeters, which is there. Now, the ELITA is based comparison. The IFS, it's a much smaller box as compared to the IFS, but if you look at the interlace that was there, which is the IFS, which is, so from a 600 to 800 femtoseconds, the time duration has gone down to 150 femtoseconds. That means that the time for which the laser fires is only 150 femtoseconds. And as you can see that the pulse duration has gone significantly, the pulse frequency has gone significantly higher. That means it's 10 megahertz as compared to 50 kilohertz. So a much faster laser that is there. Spot size has been reduced from 3 microns to 1.3 microns. Wavelength obviously remains about the same. So if you compare it with the VisuMax 500, this is a comparison with the VisuMax 500, you can again see that the femtosecond, it fires, the ELITA fires for an average of say 150 femtoseconds, while the VisuMax is close to about anywhere between 220 to 580. The pulse energy that is there is only 50 to 70 nanojoules with zero spot separation. So this is something important that I'm trying to re-emphasize, that the separation of the lenticule becomes much easier because there is no spot separation, but the total quantity of the energy that is delivered on the cornea is much less. The other thing is that it's a fast laser, except for the Visumax 800 now. I think this is the second fastest laser, takes about 16 seconds to do that. Now let's just look at a very simple thing that my colleague Raghav did, was that if you have a paper with say a 4 micron spot, as you can see, and a 1 micron, I'm just trying to compare, you can see that there will be some skip areas and there will be some difficulty in separation, and you can see that the separation when you are having spots next to each other would be much easier. Just a simple kind of a thing. So if you have a 1 micron, 1 micron, 1 micron, you will be able to get this pretty good. So the name that has been given commercially is Silk, and which is smooth incision lenticular keratomiliosis. Well, I don't like both the names Smile and Silk, because when you Google Smile, it takes you to dental, and when you do Silk, it takes you to the cloth silk, or it takes you to Thai Airways smooth as silk. So in any case, this is the name that the company decided. So smooth incision lenticular keratomiliosis. What we did in the trial was that we started in phase 1, phase 2, phase 3, and we did amblyopic eyes first, one eye, doing between about 4 to 6 diopters. Then we went on to doing between 2 to 6. And as today, what is commercially available is -12 sphere. You can go up to 12 sphere and you can do a cell correction up to 6 diopters. But a combination of that should be 12 diopters. So that's the range in which we are working. It takes about 16 seconds. And the other advantage is that it gives you the ability to center post docking, as also do a cyclotorsion adjustment. Both of them are manual as things stand today. It's not an automated, though the company wants to link it to the eye design which is there. Now, just a broad comparison, I don't know, you might have seen this, but if you compare at the lasers that are available commercially today, these are the 5 lasers that are available commercially. The important thing is the pulse repetition rate. You can see here that the pulse repetition rate, the Zemer is a very fast laser, and then comes the Elita Johnson, this thing. The energy per pulse, if you look at it, there is a wide variation in the Visumax, but you can see that this delivers the least amount of energy. The time taken, as I told you, 800 scores a little over Elita, but then this is the second fastest laser which is there. Patient interface, there are 2 companies which are giving flat patient interface, and that's the Zemer and the Elita, while the others have a curved interface. Cyclotorsion compensation, except in the Visumax 500, is available, and inbuilt centration system Visumax 500 didn't have. So side cuts, the ATOS Schwind possibly, and the LDV does not have a regular side cut which is there. Now let us just run you through the, this is the 2-piece suction that is there, that you do, which is on the upper side. The lower side is that you have marked. You can see these marks which are there. The suction ring that is placed, those who have used intralace, it is pretty much the same. The difference between intralace and this is that it's not a syringe through which you are getting a suction, but the suction is right onto the machine. So you have to bring this into the green area, which shows that you are applanating. You pinch the holder or the grabber which you have, and now you can see on the centration, you can move the centration and you can do a cyclotorsion. Can you see this centration has been moved, and you can see this is a cyclotorsion compensation that we are doing. So essentially the marks that you have will allow you to do a cyclotorsion compensation, as also the centration which you have, and then it says 16.1 seconds. That's the foot switch. This is how the laser works. So you can see that the laser is working. This is the side cut that is coming. This is again the cap cut which comes, and this is the entry cut. The big advantage of the entry cut is that it goes over it about 8 times. So it is like you are cutting through a warm knife in butter. You have never had a problem at all in the entry cut. So this is the end of the procedure. Now, the advantage of this entire thing is that the docking is pretty easy. We have not had suction losses because the pressure goes up pretty significantly, and the dock is, there may be a little problem in small eyes, but we are looking at having a single piece patient interface coming in pretty soon, and this single piece patient interface would be about 2.5 millimeters smaller than the size of the present patient interface which is there. There is a computer monitored vacuum, so which provides a strong vacuum. Patient interface, as you see here, this is a two-piece patient interface. This goes under the machine and this goes onto the eye. This also goes onto the machine to give you the suction onto the patient. Another important thing is that it has the widest numerical aperture, so the focusing mechanism is considered to be the very best. Also, there is a auto Z calibration that compensates for thickness and tilt. So any PI is first scanned, and if there is any tilt compensation that is required, that needs to be done. And the flat applanation will give you precise laser pulses across the entire treatment area. Now, this is just to show you that as there was a discussion recently, just a few minutes ago, between Dr. Shri Ganesh, you can actually mark the visual axis. So you mark the visual axis of the patient and you can see it and you can alter the centration. Now, this is in the trials, this is the early phases that we did, and this is the lenticule and the OCT guided, because we were just wanting to show as to the ease of going into the plane. And the only thing is, a very nice picture which Rohit has is that because it's a biconvex lenticule, it is like kicking a football, like you have to go like this on the anterior plane. That's about it. And this is going into the posterior. You can easily identify the two planes which are there. And then you watch over time, you can see that as you go in, there is absolutely no need. So we will call it as almost no dissection, because there is no tissue bridges that you have. The anterior is really a piece of cake. You can see this onto the OCT image, that it's really very easy to go in without having any problem as such in dissection. Now, when you come to the posterior plane, again you can see there is very little resistance. The only place where you may get a little resistance, and which I love, is 3 o'clock and 9 o'clock. When you have a little resistance, it does not fold over. So that is why it gives you a very good grip on both these sides, and you can see that you can easily go ahead and remove this lenticule, as you can see in this particular case, and that is the meniscus that is there, the sign of the lenticule. You can see it's a nice biconvex lenticule which you can see on the OCT, and then you can easily pull out the lenticule that is there without any problems. Just very fast, quick video. This is what we are seeing commercially. This is easy going in, again going out, and then you can see no dissection. That is all that I'm trying to say, is that it's such a easy piece. We have not had any instances of any retained lenticule which is there, and so is the case, I think, with Dr. Rohit Shetty. And you can see this is really very easy dissection, because the only one trick that I have to say is that just moisten the cornea before you actually do the docking. Because that will not allow any dark spots to happen. So this is the only thing. Now I'll just come on to the results long term. These are patients 18 years or old. I'll just take 2-3 minutes more. Discontinue contact lenses. This was phase 1, phase 2, phase 3 normal study design that is there. Prospective, multi-center, 2 sites in India. That was Center for Sight Delhi and NN in Bangalore. Open label bilateral lenticule, 170 treated eyes. And we looked at the mean pre-op and the uncorrected and the best corrected which was there. So this is the study results that have been published. So surgeons rated the ease of lenticule removal to be no or mild dissection in 85% of the cases. Uncorrected visual acuity or 20/20 or better was seen at 12-month follow-up in 100% of the eyes. And the MRSC was within half a diopter of 0 in 91% of the eyes at 6 months visit. Subjects were slightly undercorrected. So we have done 2 nomogram adjustments. The first nomogram adjustment that we did was to add minus 0.25 with about a 5.25% on to every negative, and that brought us much nearer to the emetropia that we were looking. And the second, we added also a slight overcorrection in the astigmatism. So you can see that mean MRSC was at an average of 0.32, as you can see, and there was no loss of best corrected visual acuity. So very tight groups, and there is a second adjustment that has happened after these results, which is this. Easy and smooth lenticular extraction. 91% of the doctors have felt that there is little or no dissection that is required in these particular cases. The corneas look fantastic. Day one, you can see that it is clear, and we are tending to have a great number of patients who are 20/20 on day one. This, I think, I'll leave to the next talk, but micro distortions in the Bowman layers have been reported by several Chinese. Even Rohit has reported, which causes a problem in the other lenticular extractions. But confocal microscopy has shown, the OCT has shown that the micro distortions are the least in this particular case of silk, which is there. This is just to show from our trials, the higher order abrasions. There is the least induction of higher order abrasions that you get in the cases of silk as compared to the normal cases, which is there. This is just again to show you one of our cases as to the wavefront deformation that you are getting in these particular cases. To sum up, I will say that the results have been excellent. It lives up to the name silk, which is smooth incision lenticular extraction. Important low time, no suction loss, ease of dissection. There is minor or no tissue adhesions. All cases had complete lenticular removal. There was no difficulty. Again, a hallmark. Entry cut is fantastic. Plane identification is also relatively easy. Day one, you have clear corneas with great fast recovery that you have accurate refractive correction. The results have become exceptionally tight, and I have yet to, and I think Rohit's group has yet to retreat any patient who has had silk. We go back now to at least about 3-4 years of data that is there, and the patient satisfaction is pretty good. So this is what I wish to introduce in this session for the silk which is there. So finally, I would say that good centration of the suction ring is important. Sometimes you have to alter the head and the neck position so that the suction is good. You need to moisten the cornea slightly before firing the laser. Approach the identifying planes, and the type of patients to start with obviously should be compliant, and proper instrumentations are required. So I think with these tips, anybody who has done lenticle extraction, it will be really easy for a person to adapt to this particular technology. So friends, this is the starting that we have for a new generational leap in corneal refractive surgery. We will soon be looking at the intacs as also for the PK coming in. The flap is already there. I haven't talked about the flap, but our first trials were to do a flap, and everyone has graded the smoothness and the ease of removal of lifting of the flap to be better than the IFS that we have done. And the thickness of the flap has been pretty good. So this is what I wish to say, and thank you very much for your kind attention on this particular laser. Thank you.
It's just amazing to be here after all of the clinical trials that we've been doing with Dr. Shetty, and so I think this is fantastic for us. And I wanted to come with this one and be a little bit brief. I think Dr. Mahipal did a fantastic job of really covering our technology at a very high level. I wanted to speak to it a little bit more just from the design perspective and the way we approach this project. Right, and so what we were set out to do was really to go after exceptional precision and performance, and that was really going down to the patient experience, the patient outcomes, but also the surgeon experience, right? You saw that from the ease of lenticle removal videos. We've seen that talked about in terms of the patient outcomes as well. And so, getting invited to a meeting. Let's see. And so we made design decisions along the way. Ronald from Zeiss set up very perfectly for us this morning with the discussions they had around, these were the design decisions we had with the Visumax 800. We made some different design decisions, obviously, than they did, which I think is really differentiating for us, right? And so as we talk about the So, all right, thank you. So as we talk about the design decisions we made, right, we really came down to the laser we chose, right? So we know we have a 10 megahertz laser that's able to deliver laser spots very, very fast, right? And that same laser is also able to deliver with a pulse duration of 150 femtoseconds, right? Which is very, very fast as well, which means that if you couple that with our optical design, which is allowing us to get down to a spot size of 1 micron, those two things allow us to get cavitation bubbles that form at a very low energy, right? And so as we've seen, the energies that we're using are somewhere between 40 to 55 nanojoules, depending on the system that you're using. And again, that's really tuned to your particular laser that you have. And so as we talk about then the next thing that we do, we know we have a lot of spots. We know we have a very small pulse. What we do with that is that we're able to actually move that objective back and forth with an XY stage, and then control the focus up and down in the Z direction very quickly as well. And we're able to actually do a raster scanning pattern of basically moving the spot back and forth, and then moving that spot, basically creating a line and translating that line back and forth to create a lenticle. Same thing, same technology we have for our flap as well that we're using. And so what this does, because we have these very small spots, because we have this very little, low energy, we're getting very little disruption, and because they're touching each other, we don't get really tissue bridges. It just makes it very easy. So these were all the things that we said and thought about as we were going back to what's going to give you very easy surgical outcomes, right? This is what we wanted to go after. We knew we had to get this technology to have the small spot size to be able to work with this fast resonance scanner, with this fast scanning mechanism. So the last thing we know about it is just also our delivery system. We know we have to be very precise. If you were talking about 1 micron spots, you have to be able to control them very precisely as well. And so we have in our system what we call our patient interface scanner. It also references an auto Z signal, right? But this is actually us having a photodetector in the system that allows us to measure precisely the energy that's reflected back from the laser when it hits the surface. So we actually, at the start of every procedure, you put a cone on. We use the laser at very low energy to actually measure the position of that patient interface glass, correct for any tilt or thickness variation in the glass, and that's automatically corrected for in the treatment delivery algorithms. And so really, we talk about this, we talk about our moving stage and our moving objective that we have. This is able to give us a very fine precision control across the entire field of view, up to 10 millimeters. So we saw this slide basically earlier. I just wanted to come back to it a little bit, and I'll talk about it a little bit more as well on the next slide, trying to cover a few of the topics that we have. But really, we went through different discussions as well on the design of this lenticle. In terms of biconvex, should it be plano-convex, and other versions of that. And we really came up with, based on modeling and other feedback tissue experiments, that this was going to be the best design for us, right? What kind of the thinking behind it is that with this biconvex lenticle, we're able to cut deeper at the edges of the cornea, preserving more anterior stroma while still keeping the thickness in the center, or residual bed thickness, varies as long as possible, right? So if we do 110, the sides, we're still able to get 150 micron depth at the edges of the lenticle, which is going to vary a little bit depending on the treatment, of course, right? If with a plano-convex, you'd have to move the entire treatment down to 150 to get the same effect, right? So which is at the same time going to reduce your residual bed thickness. And so we think, we've seen the evidence on fast nerve regeneration as well, spherical aberration, and we also don't talk about that much, but we have this transition zone. It's one of the things that really stands out to people too. They see these little wings on the side of the lenticle, and they kind of ask what they're for, and they actually serve a very important purpose for us. Right, they're there, they actually kind of extend that optical zone. We talked about this a little bit yesterday, about what the effective optical zone is. And kind of wanted to come back to this a little bit and talk about how we came to this design and what this is doing. So as we think about the biomechanics of a lenticle creation, right, kind of coming back to the theories behind the Munderland formula and how this works for PRK, how this works for flap, right, we're basically assuming that there's no change in curvature of the posterior surface of the cornea, right, and if there's a free cap, or a free flap, that's just going to fall down. There's nothing constraining it there. But when we have a lenticle procedure, that cap, the anterior surface of the cornea, is constrained along most of it, right? So you're actually having a constrained cap that's has to basically move back. It's pushed back towards the posterior stroma. And this is what, basically now you're compressing this tissue to fit into the space, which is what leads to things like Bowman's folds, right? And so as we think about how do we get around that? How do we work with that, knowing that we're going to have this constrained cap surface, right? This is going to create a lot of bending at the edges of this, right, of this lenticle as its surface needs to come back and meet up. And so what we have with this transition zone is it actually extends that bending area further away from the optical zone, which effectively makes, right, for a wider optical zone for us. We also did pretty extensive modeling to look at different transition zones and designs and think about how that design there is actually going to affect how the surface looks, right? This is the point at which the bending is going to happen, right? You can actually fairly significantly change some of the higher order aberrations induced just by changing this transition zone. As funny as it thinks that it's all the way out there, but because that cap surface is connected across the entire cornea, right, you see it's changed shape kind of as one, right? It's really dependent on the boundary conditions there. So just a little bit more on kind of the shape two. You've seen this from the patterns that we have as well. From the cutting patterns, you know we have a radial scan for our silk procedure, right? So we have a scan line moving back and forth. We're translating that scan line back and forth radially to approximate this toric surface. And so we have not only do we have spots that are adjacent to each other, we have most of the lenticles actually cut multiple times by multiple passes. And this further really gives us a lenticle, a tissue bridge-free dissection, right? And so we've seen that when we have just a single pass area, or even when we are looking at flap and we have single pass areas, that the dissection was not as easy as it is when we have multiple passes going through the same area. So that's something that we found is really helpful in improving the ease of extraction, but it's also not leading to any additional damage when we do this as well. So that's one of the things we were worried about. We've seen the evidence on, right, affected tissue area. So that's why we think at least that it's really about the pulse energy and the initial cavitation bubble that you're able to form, and not the extra energy from the additional spot spacing. It doesn't seem to be creating any issues for us with this design. So I wanted to come back to a couple of topics we talked about earlier too, just about on energy. The topic brought up about energy monitoring and how are you able to actually track that a little bit. And one of the things that we want to talk about too here was just the remote connectivity as well. So with these systems, if they're plugged into the internet, we have what's called Chime Advisor. It's a service that's actually going to give the service team and actually R&D some access to go in and look at the log files on your system. And we can actually go and do remote diagnostics and troubleshooting. So we can get really wide collaboration across R&D and service teams to look at these systems and say, okay, is there going to be an issue? This is a feature we're going to be continuing to build out as well, right, with additional diagnostics, advanced AI models to try to look and predict when the system's starting to get into a range where it says, okay, it might be time to schedule a service visit in 2 months, 3 months, or 1 month kind of thing. So I did want to bring that up as another topic. So.
We had very long discussions about does a lenticule actually have an impact on the quality of vision. So I'll just present it here. The debate of whether it does or not, we'll keep it when we go for the wine and the order session. So this is in graphics created by one of our fellows, which looks at nerve tracking. When you look at the nerve healing, when you are having a periphery which is more deeper, so you're tracking, one of the most important thing is that you hardly change it. And this was 86 eyes, which were part of the initial phase of work which we did. And what happens is, there may be multiple reasons what nerves does to the eye. But one thing is that you hardly, the nerves and epithelium, if you go back to the next slide, have a very nice hemostasis. That means if an epithelium, the next slide, the epithelium, if this is if you look at LASIK, you look at the LASIK, this is what we had worked many years back. The nerves healing is completely different, and this is down as the same. This is on 86 odd eyes, and 86 of them consistently show the same recovery with very minimal change. This could be related, you can argue, and we are seeing something similar also with the other lenticle profile uses, like ETOS also uses some kind of a similar semi-biconvex shape. They also show a same recovery, or it's related to the dose of energy we are using. You can have a lot of debates on that, but one thing is, there is proof in clear evidence that it heals and it is nerve protectant. That's the first thing. And then 86 eyes is a big number. And this was the eyes with Maipal sir and me. We were part of this trial, and this was part of the work which we did this during COVID. So we had a lot of time to analyze the nerves, analyze everything, because we had no other work for those 1 year. All we did was working on this with patients and confocal. That's why this is one of my favorite work, because it's got a lot of time and efforts into it. And if we go to the next slide here, and what does this evidence show? The nerves like this doesn't mean anything. This could be a very good nerves, but we need to understand what it actually secretes, what this dying nerves secrete, what the healthy nerves secrete. And that's very important. That is what we collect all these tears, and from the lab you have seen these people working on it. And this was contralateral on LASIK and multiple other factors. There are there are many more, but there are three important nerve factors. There was MPY, the NGF, nerve growth factor, and VEGF. And all of them are secreted in, VEGF is very important for the ocular surface in many ways, because VEGF promotes the functional and anatomical recovery of peripheral nerves. VEGF is nerves. More VEGF is nerves. So we have to understand what we block is different VEGF in the vascular, and this is nerves here. And this helps in epithelial healing and anti-nociceptive. That means if you have a high level of NPY, it makes you feel less irritant to anything around you. Air, water, pressure, fluid, cold. And that's why it's called a anti-nociceptive. So what we looked at here was that your factors in silk, all these factors, even the anti-nociceptives were very high compared to what you do is in LASIK and other procedures, which just means that your nerves here are not just anatomically well placed, they're actually physiologically and molecularly secreting factors which is necessary for health. You would wonder, why do you need all this? You would wonder, because it's just not about dry eye. Let's not look at nerves related to dry eye. Nerves are not just dry eye mediated. Nerves have multiple other roles. Nerves have roles in epithelium. Nerves have roles in keratocyte. Nerves have roles in sin. They have a role in everything. That is why they have a very good, we call it the hemostatic mechanism of the eye is driven by nerves. And these nerves have a tremendous potential to be your protectant in both in healthy and in an unhealthy status. So let's not just look only from the dry eye perspective. At this point of time, in a biological sense, nerves are not just a dry eye mediators. So this evidence clearly suggests that you need these factors not to be disturbed. And when they are not disturbed, that means that you're not disturbing the nerves. So there are two things here. You have a beautiful anatomical correlation and you have beautiful molecular correlation of this. And these two combine very beautifully. What it does in future is very difficult because it's all new things. But one thing is it makes your epithelium heal healthy, and that's what we've been talking about it. I think both Raghav, Rahil, and Rushad, over time you'll see that epithelial remodeling will hardly be any, there'll be no remodeling at all because there is nothing to remodel because all of them are having that protectin. The second factor which I feel is very important, which I think Maipal sir also did mention, which again we'll debate probably in the evening, is all the DOF data, which is done by both Maipal sirs, Rushad, and all the different DOF data, at least from the Indian thing, does show that it is very, very good, as close to an emetro, even after do this surgery. So why does it happen? And this is a complaint which we hardly see. Happens because when you look at an adaptive optics work, adaptive optics is nothing but what it does is it's like a phoropter which changes your aberrations. It's a research tool. When you can actually play with your aberrations, like how you play with your refractions. When you do that, your higher order and lower order aberrations can be changed, increased, or you can block it. So when you do a LASIK surgery, everybody knows that it will cause flattening in the center, and we all know that it would change these spherical aberrations over time. And you can change towards more of a positive error. So we would probably, if you want to create a more better optical system, you need to add more of negative SA to bring it to the same quality. I'm talking about quality. I'm talking about like MTF, what I mentioned. I'm not talking about Snell iniquity chart. But when you look at more spherically less induced, you hardly need any change in your aberration. That means patient does not require any change in your aberration. He is comfortable with whatever aberration he's got it. That means he's got it after surgery. That means you don't need a change. You don't need to induce more negative because your change is just around 0.20 or less of SA, which is very, very difficult to achieve in a conventional LASIK platforms today. We have to build platforms. Now, what are we achieving in these kind of thing is you are achieving a very organized spherical aberration control into your system. Now, how does it help is, in future, if companies like this or companies which has this kind of feature would like to get into a presbyopic solution, it is very easy for them to do it because you're already in very close to an emetrope stage. And what I see, which I will share the data now, when I looked at my data, which I would request Professor Maipal also to have this data looked, and your cohort, when you did your cohort of patients between 38 and 40, 48 or 49 years, these are patients whom we call it as pre-presbyopes. What we found very interesting was, if Abhijit is here, so this is a data which is very interesting for all lenticule companies who are looking at it, because when you look at pre-presbyopes, this was the data which we all had. And when we did a depth of focus. This is what happens when you are pre-presbyope. You lose depth of focus. You need reading distance. These are all myopes. That means they don't have a good depth of focus to begin with. When you do a depth of focus of that 38 to 47-year-old who needs reading glasses, surprisingly, we compared with the presbyopic patients, this is the orange color, who at that age, who never had myopia, who has his own depth of focus. When we compare to it, what is interesting here is that the patient with the biconvex shape had a very similar or sometimes even better depth of focus than what you see in emetrope of the pre-presbyopic or presbyopic era age group. So what it does mean is it requires lower accommodation to achieve visual acuity similar, and this is a good amount of around 26 or 27 patients which we were able to compare. We have not done this work with the other companies. I'm sure if you have that profile, I think it's worth doing it. So I may be very in a hypothetical sense, which we might discuss later in our hypothetical modeling in the evening, that we may be creating, I'm excited about this, it may be creating like a mini EDOF on your cornea. your extended depth of focus. This might help, and this might help in companies of future to create a model for different age group, because this is a fantastic data to show that it helps in giving better depth of focus when you're turning 40. This may not be when you're doing 25-year-old like how we do in Indian continent, we don't have to worry about it because this is not a great thing. But we have to understand, I'm sure in Korea, in Japan, in Europe, and America, people who get LASIK surgeries are after 35, 36, 34. The age group is 1 decade later. And for them, this probably might have an impact. Would you like to explain in a few slides, few minutes, so that, because this is something which is very important for everybody, because each profile brings in different level of it. And I will be very interested to see the profile of both the hetos and silk, because this is new data which we had from our cohort. I'll come back to you. Let Abhijit explain quickly.
Yeah, it's just to explain the method of measurement here. So we use the eye trace, which is an ocular aberrometer. And the eye trace has a placido disc, which also allows us to see the corneal topography. The disc has a small hole in the center, so that allows the patient to read if you put a Snellen's chart in front of it, in front of the device. So you can do assessment of the visual acuity at distance, intermediate, and near, while simultaneously recording what the ocular aberrometry of the patient is with the device. So what you see in the first graph is the mean, the MRSE that was given by the device. Yeah. Yeah, so what you see here is basically the MRSE of the that was measured in the patients at distance and then intermediate near. And correspondingly, what was the visual acuity also that was reported by the patient. So what you see here is clearly the difference at the near target, where if you see the untreated eyes, you know, they are somewhere around here, but the patients who had undergone silk, you know, they had actually better VA at the near target. At intermediate, they were quite similar. And, you know, there's no specific nomogram adjustment being done to achieve this. We are targeting emetropia in both the eyes for the silk patients. And correspondingly, if you see the amount of defocus that was induced in the patients, because you are asking them to read, right, at different targets, you see that the silk eyes are actually doing around quarter to half a diopter excess accommodation at near after the surgery. So there seems to be a definite benefit as far as the surgery is concerned, which is being given to the patients. Yeah.
Can I clarify?
Yeah.
Can I clarify with you?
Yeah.
Rohit, the changes you're demonstrating both in terms of nerve fibre, preservation, regeneration, as compared with LASIK. And secondly, the preservation of spherical aberration, not inducing extra spherical aberration. Are these changes unique to a biconvex lenticule, or are they intrinsic in the fact we're doing lenticule rather than surface laser?
I've not done a head-on comparison of a same patient, one to the other side. But I would like to believe and that it might be related to both the energy, the energies what we use, and also to the shape. I'm not entirely to the shape itself, which is the lowest energies we are using, and every company is coming lower now, and the way the spots and other things are organized. But this one, what you see here, so this is something which I would be more excited for my 38-year-old, 37-year-old patient with the myop, because I know that I'm getting him a better, and this is consistent for 27, 28 patients. So it's not like one patient had it. So it might be because there might be the way how cornea is modeling, and that is what we're going to discuss in the evening, because I don't want to make you wait for the lunch, because we will have a separate session of what model with Abhijit has, why should it create this kind of thing.
Just one quick comment, sir. So based on this, it's a very exciting thing in the Zimmer Z8. We are actually using the Q value, and currently we just preserve the Q value of the treatment naive cornea. But it does give us the opportunity to actually use the VAO
But that's
system.
why, you know, when you start looking at depth of focus about them, and see whether what you're giving, whether you're giving the same thing. That would be interesting.
Exactly. So we can actually use the VAO system to assess what is the depth of focus or the spherical abrasion that the patient can tolerate, and actually create a spherical abrasion profile that post-treatment can actually give the patient
Exactly. See, the whole idea of adaptive optics is, can you go back please? Adaptive optics is that if you're using your, if you're using, the adaptive optics, if you're using a particular amount of assay, which you're balancing your assay through your Q values. So if your assay with your wow, which is your adaptive optics, so that means if your assay does not, you don't need to titrate your assay, you're happy with what you have, that means you've achieved that your machine is giving what you enter. So in LASIK, you cannot get what you have because there's a lot of other wound modulation which would probably change your assay and other things. That's what the basic understanding is. So this is exactly what it is. If your Q value is exactly what you're feeding in, then you should not have any changes from what is perceived to what you expect. So this is exactly what you need, and this is what you need to work on.
So just a comment. I mean, we don't have confocal, but the thermography studies that we've done kind of correlate very well with what you were saying regarding the neuropathic pain component being less in
Absolutely none, because your nerve growth factors, NPY, VEGF-A, is responsible for your neuropathic pains. Those people who complain that when I go out into sunlight, my eye waters. When I'm in the AC, my eye hurts. These two complaints are completely driven by these two factors. They're not your dry eye parameters, they are your nociceptive ones. For example, this is your nociceptive. This is your nociceptive. When I go into AC, my eye, I cannot tolerate AC. This is because your anti-nociceptive is very low. Right, Arka? That is where you taking a lead. Not about dry eye today is not a big issue. It's about the quality of life what you have. We have a last talk by Dr. Andrew.
Rohit, just one question. Have you seen a difference between different refractive errors corrected?
Which one? This one? No.
So out of those 27 patients, some may have been corrected for -1, some for -5. And do you find that the amplitude difference is there?
No, this was very tightly controlled. This was part of my pulses and our cohort, which was -2 to -4 or -5. So it was not, it didn't have too much of variation. The variation.
So no high minus?
No, it was not high.